is April 11th, and whereas the date may not immediately stand out to many as a particularly important date, it marks the beginning of Black Maternal Health Week. Over the course of the next 7 days, we will work to bring attention to the rates of maternal morbidity and mortality in Black women, which is significantly higher than that of American women and other racial groups. To help us better understand this issue and its importance, we are joined today by Dr. Gina Johnson, Medical Director of Pediatrics at Northeast Valley Health Corporation in San Fernando. Dr. Johnson, welcome to the Jedi Podcast.
Thank you. It's a pleasure to be here.
Before we move on to the specifics of today's topic, I would like to ask you about the broader importance of the month of April. It turns out that this is actually National Minority Health Month, and I would like to ask if you could help us to better understand its importance, specifically as it relates to health equity.
Yes. Thank you so much for allowing me to share a little bit more about the importance of National Minority Health Month. As it turns out, the number of Black men in medical school has not changed since the 1970s. And this really impacts the health equity of our patient population. We know that people of color are more likely to go back to work in communities of color and to serve the community from which they've come. We also know that more than 1 in 4 Black Californians avoids care due to concerns that they'll be treated unfairly or with disrespect, and that many Black Californians actually adopt measures to mitigate potential negative experiences in preparation for health care visits. 2/3 of Black Californians report researching a health condition or concern before meeting with a health provider, and over 1/3 say that they've tailored their speech and or behavior to make their provider feel more at ease. So you can imagine if you've engaged in those kinds of behaviors prior to your visit with the provider, having more representation in your healthcare setting will provide a much more equitable response in the healthcare setting and result in much better care.
As I was preparing for this interview, I came across some astonishing data which show that Black women have a higher rate of preterm births, low birth rates, and births for which they receive either late prenatal care or no prenatal care at all compared to their white counterparts. Can you tell us what are the key factors driving this asymmetry in prenatal care between these groups?
Yeah, so there are a lot of key factors, unfortunately, that are driving these disparities. Some are related to genetics and epigenetics, and we'll talk further about that, I think, as we go on in the interview. But we also know that Black women are more likely than white women to report using a contraceptive method that's associated with a lower efficacy, so something like withdrawal or condoms as opposed to a more efficacious type of birth control. We also know that Black women are disproportionately lack necessary reproductive health care, including contraceptive access and counseling. And then, of course, that is going to result in later detection of pregnancy and later connection with healthcare facilities to address their pregnancies. And then, of course, there are issues like implicit bias and concern that they're going to be treated unfairly when they actually arrive at the healthcare center. There's, of course, the risk of the increased reporting of child abuse, and we know that with late prenatal care, oftentimes these women will be tested for substance use, and that may put them in contact with the DCFS system as well as with the justice system, which can put their whole life and livelihoods at risk.
Thank you. I also found pregnancy-related mortality rates for Black women to be 3 times higher compared to the rate for white women. How can this fact be explained?
Yes, so this really, we begin to get into some genetic and epigenetic abnormalities. So women of color are more likely to have pregnancy-induced hypertension, and that may be related to genetic changes that have occurred as a consequence of the Middle Passage. People were much more likely to survive their Middle Passage from Africa, that long boat ride from Africa over to the US, if they were able to maintain their blood pressure with minimal access to water and salt. And so genetically, the people who came to the U.S. As slaves became more likely to develop hypertension. Pregnancy-induced hypertension, of course, is not a good outcome does not result in good outcomes for our children, including the fact that oftentimes those will be preterm births and that they may result also in consequences for the mothers as well. Epigenetic changes we know are associated with things like adverse childhood experiences, which are very frequent in women who are raised in poverty. So adverse childhood experiences include things like exposure to racism, include things like inadequate food supplies during their childhood, include exposure to someone who has been engaged with the justice system, including separation from your parents for any reason, and those result in actual changes in the expression of genes in the families, the women who may go on to deliver babies that may be born early, may be born smaller, and the consequences continue for the next generation as well.
Now, as we all know, COVID did not make things better for anyone. In fact, maternal death rates increased for all racial groups during COVID. However, Black women not only experienced the highest increase in maternal mortality rates across the racial groups, they also experienced the largest increase when compared to the year prior to the pandemic. Can you help us to understand these increases and what they mean?
Yes. So these increases are devastating, and we can only hope that we're able to reverse them quickly. We know that COVID infection and pregnancy did not result in good outcomes. Being infected with COVID increased the risk of, again, preterm birth, the risk of hospitalization for the parent, and poor outcomes in the health of the parent as well as the child. We also know that in our communities of color, uptake of the COVID-19 vaccine was much lower than the uptake of the vaccine in other communities. And the legacy, the unfortunate legacy of the Tuskegee experiment meant that African Americans in particular were at increased risk for distrust around the healthcare messages that were put out during COVID, and so delayed vaccination. That resulted in what I believe the largest increase that we have seen with regard to the disparity in pregnancy outcomes for African American women and for white women.
Dr. Johnson, as I'm sure that you're apprised, education is often seen as a great equalizer when it comes to combating the effects of racism and discrimination. However, data from UCLA suggests that Black women with a college degree are up to 5 times more likely to die from pregnancy-related complications than white women with a similar level of education. Tell us, what makes this counterintuitive finding possible?
Yeah, I'm sure that many of you are aware of the pregnancy outcomes of famous athletes like Serena Williams and Allison Felix, well-educated, well-spoken African-American women who wound up with newborns facing challenges. And this is definitely something that we see in many of our more affluent African American women. I have a friend who recently had a baby January of this year, and his wife went to the hospital for pregnancy-induced hypertension. She was going to be induced early to deliver her baby. When they put in the IV into her hand, she began to complain that she was having some pain. And many of the nurses, as they came through, said, sometimes the IV hurts a little bit. Maybe, you need to really think about what else is going on, take some deep breaths, do some other things. They had to ask many times, many different people to help them with the IV. And finally, once she delivered the baby, they found that her IV had been infiltrated by fluids, and to this day, she continues to not be able to use her right hand at times to pick up her newborn baby. And as she expressed to her husband during this delivery process, when he was saying, "Come on, tell them how much it's hurting you," she said, I don't want to be known as the angry Black woman. I don't want these perceptions that people often have to come true. So perhaps she appeared a little bit more stoic, and perhaps they weren't able to recognize how much much pain she was in, and so didn't really address that issue. Also, we know that findings look different on the skin of dark colored skin. So for instance, maybe in someone with lighter skin, you'd be able to see that fluid going through and the redness and the irritation. But because maybe the nursing staff and the staff was not as familiar with looking at skin of color, they weren't able to recognize those changes. So we know there's implicit bias. We know there's just true bias, and then also on the side of many African American women, we maybe are concerned about the perception that's going to be brought, and so maybe don't express ourselves as well as we would like to receive the care that we need to receive.
I'm sure that you'll agree that the statistics surrounding this topic are bleak. Can you help us understand what measures can be taken to start the journey toward achieving health equity as it pertains to Black maternal health?
Yes, the statistics are bleak, but there is much hope, and I do really want to highlight some things that are already happening. So the Congress passed the PUMP Act for women, allowing women to use 2 years of accommodations after they deliver their newborns, including having nursing, being able to breastfeed their babies at their workplace for 2 years. So that's already in process. That's going to increase the well-being of both the mothers and the babies that are coming. The California did a survey again early 2022, and from Black Californians, these are some of their thoughts on ways that we could improve health equity. Increase Black representation among healthcare leadership and in the healthcare workforce, as well as establishing more community-based clinics. Expanding community-based education on how to navigate the healthcare system and advocate for quality care, and increasing the number of Black community healthcare advocates. Another great asset that has come in the state of California is that doulas are now a funded opportunity for women who are in their pregnancy and in their delivery process. They are actually reimbursable under the state Medicaid program to have a doula to help them through that pregnancy and delivery system, and that is a wonderful person who can advocate for them. And finally, to establish accountability for equitable care by implementing financial and accreditation incentives in the healthcare system, as well as through provider training. So I know that as a pediatrician who sees newborns at one of our local hospitals, in the last couple of years, I actually had to do some CME training on health equity and implicit bias. And I think if we're able to improve this, expand this opportunity for all healthcare providers in the state of California, that would go a long way towards improving the care in the state of California. And then the more we do federally and nationally, the better.
Dr. Gina Johnson, thank you so much for joining us today, and we very much look forward to having you back on the podcast.
Thank you.